Good afternoon, everybody.
Good afternoon.
How's it going?
Good. Hello, Ruston.
Now, I will be back in less than 1 minute.
Join the meeting. All right, it is exactly 2 o'clock. All it looks like Mark is sending me a note saying that all of my wonderful guests have arrived, including the fabulous Harold Phillips, who I've known for 200 years. And I don't know why he now looks younger than me, but I will get to that maybe during his talk. We've got Ruston Seaman, who's the director of New Vision, and how do I pronounce that? Barber or Barber? Because I've heard it pronounced both ways.
It's in Barber County.
Barber County, okay? Because people pronounce it, and people in West Virginia, you will explain to folks later, Ruston, are very funny about how county names are pronounced. It's not Kanawha, it's not Kanawha County, it's Kanawha County for those of you who have seen it on the map. So there you have that. And then I have my good friend, Scott Thompson, who I've also known for 200 years. And he too seems to continue to look younger than I, and I don't know how this continues to happen. So the first and most important thing is that I would like to thank you all for joining us for the January 2021 meeting of the West Virginia Statewide Stakeholder Coalition that's convened.
Tammy Sowards.
Hey, how you doing?
Join the meeting.
Education group. And I really do think that where we are in the middle of our body politic, as well as in the middle of COVID-19. And like I say, I think we're in the middle. I don't think we're at the end yet. We still have other pressing public health issues to get us through. And one of those issues is certainly the impact of HIV, viral hepatitis, substance use disorder on West Virginia and on other rural communities across the United States. So today I've invited my good friend Harold to talk to us a bit about the role of the Ending the Epidemic Plan, the future of the Ending the Epidemic Plan in West Virginia, and actually in rural communities across the country. So Harold, I think you know me well enough, and I think we talked a bit about this process. And I think we've got Ruston on to talk about his group, Scott to talk about kind of what's happening in biopharmaceuticals, particularly what's happening with Merck. But Harold, I'm just going to ask you a question directly. You know, West Virginia was left out of the ending the epidemic strategy phase 1. And we have some big challenges here in this state. I guess I want to know from you, how do we get left out? What should we be thinking about moving forward, particularly as partners in HIV, Hep C, primary care, who are on this call, harm reduction, who are on this call? And because by my calculation, and I could be completely wrong on this, Harold, because I've been wrong before, but let's not say that publicly. I don't see West Virginia getting resources out of EHE until 2025, but it's the framework that we're supposed to be operating under. And how do I help the state, but also how do I help local providers get the critical resources that are needed?
So, hi, Tony. Thanks for inviting me, and good afternoon, everyone, and Happy New Year. So, like Tony said, I'm Harold Phillips. I am the Chief Operating Officer for the Ending the HIV Epidemic Initiative in the Office of the Assistant Secretary for HHS. So, to answer your question about EHE, the Ending the HIV Epidemic Initiative, and West Virginia's place within it, I want to do two things. So one is to talk about the criteria that was used to determine which would be the phase 1 jurisdictions. And West Virginia is in a phase 2 for the geographic areas. So phase 1 are those places that the counties, rather, that contribute to 50% or more of the HIV cases in the United States, as well as 7 rural states that have a disproportionate HIV burden. So Oklahoma, Missouri, Tennessee, Alabama, Mississippi, most of them are sort of in that southeastern piece. So that was the cutoff for that determination. That being said, then those are called what we call the phase 1 jurisdictions, those with that heavy HIV burden. The phase 2 jurisdictions, like you said, Tony, are supposed to come online somewhere, and I'm talking about right now what the Trump administration had planned, because we're about to transition, and there may be a new group of people who have a very different idea about how we approach the end of the HIV epidemic. So everything I say is everything that I know as of today, which could change in like 10 days or so. So, but the initial plan was that states like West Virginia and other jurisdictions would be part of phase 2, and that phase 2 would be implemented by 2025. And that part of that phase 2 was additional resources for those areas to continue controlling their HIV epidemic, especially when it comes to linkage to care, maintenance and care, and helping people get virally suppressed. And so that was the initial plan. But again, like I said, that could change in a couple months, couple weeks. But that was the plan for phase 2. That being said, the other thing that I think is important in all of this too is that the EHE initiative is part of the HHS plan that moves us toward ending the HIV epidemic. We also, hopefully by Friday, are releasing the next iteration of the HIV National Strategic Plan, which does cover the whole nation, which does identify priority population groups, and has 4 goals of both increasing diagnosis, increasing viral suppression, scaling up our prevention efforts, and then better system coordination. That covers the entire country. West Virginia, of course, will be able to see where it fits into there. And as part of the release of this plan, we're encouraging jurisdictions to think about what your local plan needs to look like and how both your comprehensive plan for HRSA and CDC aligns with these national efforts. The other thing about the federal plan is that the federal plan is not just HHS. There's been an involvement from a federal steering committee that includes HUD, the Bureau of Prisons, Office of General Counsel, Department of Labor. They've all been sort of looking at how their how their HIV work intersects with our HIV goals. And even though we've had a national strategic plan under the Obama administration, this is the first plan that says to the American public and to all of our key stakeholders that this plan is calling for us to end and control the HIV epidemic in the United States.
So Harold,
just had a broad goal.
So Harold, I warned you about this in our pre-call that I would just jump in and look at Trina Scott, who is at Gilead now, is already shaking her head because she's been doing these calls with us for a bit, so she kind of knows what's getting ready to happen now. But so Harold, and maybe I'm just a little Sam sausage head about it, right? Is that I look at it and I say, well, you've got West Virginia, which has had these, they like to call the new scientific language is clusters, right? But they're actually outbreaks. They're actually something that I think needs an urgent and not just a systemic response, but an urgent response. So why is it that there was no provision in the ending the epidemic phase 1, phase 2 for outbreaks? I mean, because that's what this was. This isn't a cluster. These are outbreaks, and I think that we like to use language that makes it, to me, it's kind of like using we're gonna correct stigma when stigma is really about racism, homophobia, gender inequity, racism. So those are really big things, but we put them in a little word like stigma, it really sounds like you might be able to do something about it. So I think it's the same thing with a cluster. It's like maybe if instead of saying it's an outbreak, maybe we talk about it as a cluster, we feel like we could do something about it. And I know Lauren Canary has joined on this call, and I'm hoping that she has a question for you too along these same lines. And I didn't mean to put Lauren on the spot, but I did. And so, because it's also about the cluster, but it's also about the connection to HIV, viral hepatitis, substance use disorder. And West Virginia is, in a state, let's just, no pun intended with it being in a state. That was a joke for the kids in the back of the room.
Hey, Tony, this is Lauren here. Thanks for letting me be on. I can't agree with you more, Tony, that I actually was on the HIV response while I was an epidemiologist at CDC. We had the cluster in Huntington, and that was my big question serving on that team was, when are we going to call this what it is? And by the definitions of a cluster, you have to kind of confirm that indeed it is localized to one given geographic area. And I don't think that there was enough HIV testing being done throughout Southern West Virginia to really confirm that this was an isolated cluster rather than really perhaps a more widespread problem. And I fear that by using that terminology of cluster, pretending that this is limited to one city, despite evidence to the contrary with molecular data, that we are limiting our response and the responsibility of government to do something about it.
All right, thanks, Lauren. So Harold, I hope you have a snack and some water there, Harold, because it's gonna be a long hour. But there you go. All right.
Right. So no, thank you for that. And you know, and when Tony and I talked about this, we really did talk about this as being a dialogue. So you probably see something very unusual here, which is a federal person without PowerPoint presentation. So we really did that on purpose so that it could be more of a dialogue. So I'll tell you, as we think about sort of the future and phase 2 and things we might like to see the new administration implement, it would be that piece around cluster detection, so that areas like West Virginia, like other phase 2 geographic areas, could monitor for outbreaks within the epidemic and be able to respond. So one of the pillars of the EHE initiative is the respond pillar. So CDC was given funding to help support monitoring for cluster outbreaks and coordinating the response among certain jurisdictions. Now, I'll tell you, of all of the 4 pillars of the initiative, which are 1, diagnose, 2, prevent, 3, treat, and 4, respond, the respond one is the one that is the most, I would say, controversial. But within the national HIV plan that I talked about earlier, I say this nicer than I am right here, but it's really like, this is a tool and we need to be using every tool possible to address the epidemic nationwide. The community has concerns about us using blood samples to detect and run tests and identify clusters. We have surveillance systems across the country that are not up to par where they should be to be able to do cluster detection and response, but it's an important tool to help us do this work. And so we need to figure out how to address the community's concerns about privacy, about what is it going to look like when DIS folks show up in the community to respond based to a cluster. Can that be done in a culturally appropriate way that provides confidentiality and privacy? Yes, it can. And so we need to be able to do that in order to move this forward. So 2 things to answer Tony's question, again, now that I've said all that, is 1, would love to see this as part of phase 2 of EHE, because we think it's very important. So that's something I think we need to talk about with the new leadership as they come in and think about what happens in the future with EHE. So cluster detection in geographic areas that were not part of phase 1 is important. And then 2, making sure that we have the systems in place to be able to do this. Because even with CDC's first round of funding last year for cluster detection under the response pillar, not every jurisdiction, not every county or state is equipped to be able to do it. So not every county or state was eligible. So that's something else to watch.
Right, and so how you bring up, and I'm gonna bring in Ruston. And Ruston, can I call you Rusty or no, or just Ruston? You're on mute.
There you go. Yeah, Ruston would be best. Thank you.
Okay, Ruston. All right. See, so you better ask people about their name. It's not just Black folk that are sensitive about it.
There you go. That's right. White folks are too. I am included.
There you go. See. So I'm going to bring in Ruston into this because it brings up a bit of the issue, right? So and so Harold, recently there was a CDC, I believe it was out of CDC and not just out of the Office of Secretary, RFA, notice for funding, that came out. And West Virginia, of course, was not included in it, but one of the priority populations was people who inject drugs. And so, Ruston, you've started an organization, and one of the things that we've been really working on here at Community Education Group is trying to work with HHS, both through the Office of the Secretary Office of Rural Health Policy and SAMHSA to increase the number of MAT, substance use disorder providers in the state who are screening and linking to care for HIV and for hepatitis. And what we found out through HRSA was that only about 27% of West Virginia's MAT providers were screening for HIV and Hep C on a regular basis and offering a linkage, a warm linkage, not just a referral to care. Ruston, how are you guys handling HIV and hepatitis in your facility?
Well, very good. Thanks for including me in this. I'm the prevention lead for our coalition. We're HRSA funded. We have a federally qualified health clinic in our county that is the provider of the MAT treatment and recovery services as well. They have gone from 4 behavioral health and treatment professionals to now they have 15. So their team has hired some of their first wave of people, and how it's going to work long term is going to be very interesting. I work on the side as a community pastor and as a community nonprofit organization. We're heavily invested in trying to go as far upstream as we can, and also being able to find the resources that are equal to the problem. And the MAT group that is doing that is trying to find all the best practices. They don't have a long history. Our HRSA grant is currently 3 months into the work. So all I can tell you at this point is I know that they have hired more staffing. They are trying to look around the state to make sure that the best practices in that field get implemented in our county. And it's some level kind of a new edge, Tony.
So Ruston, let me ask you this. So what HRSA funding are you? Are you Ryan White? Are you R Corp?
We're at the R Corp, and we were in the second implementation phase, and we dove in, and it's a great opportunity. Our county's small enough. There's only 16,000 residents. It's a substantial grant. We have a comprehensive approach trying to integrate prevention, treatment, and recovery in one geography and be successful at driving, the problem away. And
Right.
that's what's unique to our county. So we're hoping to find other people that.
What county are you, Ruston?
Barber County.
Barber, right?
We're in
And that's it.
Barber
right?
County, and that's it. And our capital city is Phillips, 3,500 people. So our ability to use this grant would mean we could comprehensively try and win in one turf some successful models of how all this gets integrated. Since we're a small enough county, people know each other. So we're very hopeful that all the handoffs should be all warm handoffs, all the relationships at the community level. It just happens quicker and more effectively if people know one another.
Right. So Ruston, if I said to you, okay, you've got the R Corp grant, but what are the other resources that you could use from your state partners, your federal partners, and your private sector partners?
I think the missing solution we found when I went to Iceland to look at the Icelandic model of prevention, and they discovered 20 years ago what I think we would uncover right now, is that at the community level where families and young people live and interact, there's almost an absence of common work and common practice. We believe there should be real staffing with real people, real budgets in real centers that function. In this public health crisis right now is, like there's only one health department for a whole county. Families live in communities. They relate in smaller groups. And if there was an intentional investment in prevention at the community level, some of these problems could be nipped in the butt sooner. And that's what prevention is all about, a better investment. So we're not spending all of our energy and time in everything related to treatment and recovery. And that's the part where I'm just learning our way forward in the public health space. we believe the approach is the right approach long-term to the ending of the pandemic. You're going to have to do some things.
Right. So I guess, Harold, I think I'm going to flip back to you a bit. So based on what Ruston is kind of saying and what, my understanding of the EHE plan is that actually this is what the EHE is supposed to do, really help jurisdictions build infrastructure, right? And then help them, because I think in my understanding, my read of it is that a part of the EHE is to help states and counties build that financial management infrastructure, fiscal management infrastructure, being able to get a grant out of the door. Because that's a bit of our challenges is that we don't really have a statewide testing program. And, with COVID, every resource right now is kind of going to COVID. And so you got DHHR, God love them, they really have a limited availability of time, money, and resource to dedicate to issues that are basically collapsing the state. Substance use disorder, HIV, COVID rollout.
So Tony, much of the EHE money is really dedicated for services that fall in line with those 4 pillars: prevention, treatment, diagnosis, and the response pillar, sort of responding to the clusters that we identified. There's not a lot of EHE money that's going toward capacity building or building organizational infrastructure. Now, CDC, through its capacity building assistance grants, its capacity CBA providers are still providing that kind of technical assistance. And HRSA is doing a little bit of technical assistance around community engagement and planning. But there's not a lot of, so we still haven't expanded that pool of capacity building assistance to deal with things like grant writing or fiscal infrastructure for organizations. For a lot of that, especially this first year of EHE, I've been trying to work with the foundations and the pharmaceutical companies to support that kind of work. Because to be honest, like Ruston was saying, when we get down to community health, we need community organizations to be able to partner with public health departments in order to truly be effective and get into the community. And I'm afraid that, like Ruston was saying, that with COVID-19, even the ones we sort of had are disappearing and struggling now. So I'm trying to work with sort of the private foundation and pharmaceutical folks to get them to take a look at this and see how they can help right away.
Well, I like how you did that, Harold. So now we're going to pivot over to Scott at Merck to talk about what Merck's offering educationally, grant-wise, and the other.
Okay, can you hear me?
We can hear you fine.
Can you see me?
See, and you look marvelous.
And I don't know how that is. I haven't had any Botox in a year, probably because of COVID. Well, thank you so much for having me, Tony. And Harold, hi to you. I haven't talked to you or seen you in a long time. So good to see your face. So as far as Merck, just for those of you who may not know, Merck has been involved in HIV since the beginning and continues to be involved at all levels. When I say at all levels, I mean not only in terms of developing therapeutics and providing them, but also at a policy level, which is an area that I don't work in, but we do a lot of work at both the federal and state policy levels. So we are continuing to work heavily with the areas around the country that are greatly impacted and those that are not. Just to give you a little bit of background, I serve as Merck's HIV Community Liaison for this area. And by this area, I mean I cover West Virginia along with the District of Columbia, which is where I live and where I'm at right now, the state of Maryland, Northern Virginia, and the state of Delaware. So in my role as an HIV Community Liaison, and I've been doing this now for 13 years on behalf of Merck, is I provide free training and education to AIDS service organizations, community-based organizations, health departments, partner with AETCs. So we do a lot of free, like I said, education in the communities, not only with providers and mid-levels and case managers and nurses, but we also work providing these types of services and educational opportunities for consumers, people living with HIV, through work supporting groups that they may have. So I do want to make sure that people understand that it's not just myself, that we also have a sales representative who lives in West Virginia, and she's on the call with us today, Tammy Sowards. And her responsibility is she covers the state of West Virginia and then a newly acquired western part of the state of Virginia. So she is mainly responsible for working with the prescribers throughout West Virginia to make sure that they are aware of our products and how best to use them. So I do want to make sure while we have this time that folks are aware that all of Merck's products, all of our HIV products are approved and available on the Ryan White ADAP program, your AIDS drug assistance program for West Virginia. And we also have a copay program where Merck will provide, Merck will provide funding to cover people's copays, their deductibles, their co-insurance for any eligible privately insured patient, including those that may get their health care through the ACA, okay? In addition to that, we have a voucher program where people can get a 30-day supply of our HIV medications for Delstrigo if the doctor thinks it's an appropriate medication. And then the last thing I want to just make sure people are aware that Merck also makes hepatitis C medication that we are not actively promoting any longer, but it is still available. And it is used quite regularly in a lot of the prisons. So some of the prisons out in West Virginia may be a therapeutic that they're using with their patients. So I'm going to pause there in case people have any questions about anything. And Tony, I'm afraid of you now, though. I saw what you started doing with Harold, so I got my coat on. I'm ready.
There you go. Well, no, this is, if you have questions, please put them in the chat box or raise your hand and I will try to get them asked and answered. This is far from a be afraid. I think only person I don't know is Ruston. And, the thing is that what I really try to do with these calls is to increase access. That's our goal, right? So that's access to Harold, access to you, access to Ruston. There are probably people out there that want to know, everything from, how did Ruston start this program, to me wanting to know from Harold, how can people, listen, I take away always, I walk away with the most, I think, important line in the national AIDS strategy. And that is that none of us can do this alone. It's going to take community, academia, local government, federal government, private partnership, and community members in order for us to end the epidemic. And what has occurred in West Virginia is that we have syndemic on top of syndemic on top of syndemic, right? So we've got brown lung, we've got bad water, we've got low educational attainment, we've got substance use disorder, we've got HIV, we've got viral hepatitis, we've got COVID. And if you haven't heard the Wall Street Journal podcast with Dr. Clay Marsh at WVU about the success that West Virginia has actually had in rolling out its COVID vaccine. I think that we do some things very well, But when it comes to HIV, I think we didn't have a HIV infrastructure in place when our HIV epidemic hit. And so now we've got to put that infrastructure in place. And we've got to build it on the back of what I consider to be non-traditional partners. In DC, Baltimore, New York, we've got HIV organizations that have been there for 2 decades. Here we don't have that. We've got Jay and the work that he's doing with Ryan White. You've got a couple other smaller organizations, but we just don't have the historical infrastructure. But now we've got groups that are doing substance use disorder, harm reduction efforts, and we've got to build HIV on those, and Hep C on those, and COVID on those, and help on those. So Harold, I know you don't probably have the answer today, but what do you see kind of going down the road? Because if we look at how we're even doing HIV prevention these days, we're really focused way more on biomedical responses than behavioral health responses. How do we include that behavioral health component, which is really kind of more of the sweet spot where these things intersect, right? Where substance use disorder intersects with HIV, Hep C, behavioral health is right there, that mental health component as a part of this.
So thanks for that, Tony. You
That was
talked
a
about
long question.
long question. So I'll try to give you a short answer to that one. You talked about the fact that this is, we need everybody involved in this. And that's been part of my job as Chief Operating Officer, which is to try to we call it the whole of society approach. So I'm working with the faith community, with the business community, with public health, with community-based organizations, with substance abuse providers, STI, viral hepatitis, pharmacists, nurses, all trying to get them to understand we've got everything we need to be able to end the HIV epidemic, but we've got to create these new partnerships and these new way of thinking in order to move things in a different direction. So you just basically summed up one part of my job description, which is to try and get society to understand this, to see where their part is in all of this, and to be able to connect and be sort of like the bridge between all of these different parts in order to move us toward that goal of ending HIV in the United States. As Ruston was talking, one of the things that I didn't do a PowerPoint, but I did go to AIDSview to check West Virginia out so I could get the most recent data. And one thing that pops up for me is the fact that 24%, almost 25%, 24.4% of your cases are late diagnosis. So the availability of HIV testing is one thing we really have to look at for West Virginia. It seems that once you sort of get them into care, most folks, I think you're somewhere around 60%, so you're slightly better than the national average, which I think is about 54%. But still, some of those factors that get in the way, like you mentioned, poverty and employment and housing status and access to clean water, all of those things impact somebody's ability to stay in care. But for the most part, you're doing better than the national average in keeping them in care and getting them virally suppressed. But with 1/4 of your population being late diagnosis, there's still a need to create new partnerships and instances where individuals can get an HIV test. So I'm excited to hear about the new HRSA-funded MAT program. That's an opportunity for HIV testing and connection. And there are others, STI clinics. One of the things we're doing this year in OASH is trying to focus and highlight on where are those missed, what's OASH? The Office of the Assistant Secretary for Health, OASH, folks that I work for in US Department of Health and Human Services. One of the things that we're doing is really trying to focus in on where are those missed opportunities? Where could we be doing more HIV testing? Emergency rooms are another one that seems to pop up, in that there's a lot of people that use the emergency room for primary care or something happens. But because they don't have a primary care provider or they're not going to an HIV testing center, that's a great opportunity to offer them an HIV test. So we're seeing a lot of the communities really thinking about where are those missed opportunities. We know in the South, we're going to do an EHG stakeholder call at the end of January, focusing on missed opportunities, because there's data that shows that many, especially African-American women in the South who go to STI clinics are not offered an HIV test, and that within a year or two, they come back with an HIV positive result, when we could have intervened earlier and connected them to the resources. To answer Tony's question about prevention and the toolbox,
Let
Tony,
me ask Ruston real quick. Ruston, do y'all screen for HIV, Hep C, and STIs, or none of the above?
Anyway,
What is an
I will
STI?
have to get with our MAT provider and ask exactly the question on how they're doing it. I don't know the answer.
Okay. Sexually transmitted infection. So we used to call them STDs,
Oh, I know.
but we didn't want people to run around thinking they were diseased, but just had a little infection they could get a shot with.
Yeah, Tony, I raised my hand, but one of the things that I found, and I work in primary care, is that.
Introduce yourself first.
Okay, this is Sarah Barton from Copeland Health Systems. And as I was working on HIV, I can't remember, funding for HIV or something, one of the things that is very common in West Virginia is that HIV and Hep C are not part of the standard STI panel. And I think that that is a huge area where training, even in primary care, because, you know, in our primary care, it was not something that was just part of the standard panel. And I think that that's an easy first, you know.
So Sarah, are you thinking that we should do education with providers to have them routinize screening for HIV and Hep C, or
Yes.
is it a different suggestion?
Yeah, I do think that it should be routine. It should be routine when you're doing an STI panel, you know, because you're already looking for infection, and it for the patient, you know, a lot of times patients aren't aware that it's not part of the screening, for one, because nobody ever talks about it. And two, or they assume that it is part of the screening, you know, so I don't know if I said that twice, sorry. But anyway, I did find that that's not a common thing with primary care providers. In our rural communities, they're very hesitant to ever say, oh, well, you know, maybe we need to do an HIV screening, because the communities are very small. And so the best way in rural communities is to make it part of a standardized panel, because then that takes away the stigma. It just takes away the stigma for both the provider and the patient.
right? Because then the provider doesn't necessarily have to do a sexual history, which some providers are uncomfortable in or not well skilled at trying to do those as well.
Yeah.
Right. Is there anyone from the state health department on? I know that they're COVIDed out, but I mean, so, because it goes to, huh?
I worked with two health departments when I was working with that particular funding group, and one had it standardized and the other one didn't. But I know, like, there's a health department in Charleston, and they do, you know, it's part of their standard panel. So it just really varies site to site.
This is
Right,
Jeanette from
and I
West
think, like-
Virginia.
Huh?
Go ahead, Tony. This is Jeanette from West Virginia.
No.
I'm sorry I was late. I was on another call. I
That's
will say
you-
that I've been doing HIV education in West Virginia now for over 30 years. trying to get healthcare providers to do testing has just been quite the challenge. We hear from a lot of community health centers, they're not reimbursed for the testing, so they don't want to do it because they're not reimbursed, especially if they're the type of community health center that gets just X amount of money for a physical for that patient. So it's like they're paying out extra for that. That has been one issue. The other has been, even though our state laws changed in 2011, there's still people who think that they still have to get special permission and it has to be hidden somewhere in the chart, and all the things that have changed over time. And, you know, when we provide education, I frequently get asked about those types of things. Well, don't we have to keep this special? And don't we have to put it in a special spot? And the last thing, I think the reason they don't do testing is because what do we do if we find someone who's positive?
Right. No, I mean, well, I actually think that you've hit the nail on the proverbial head, right? Is that if we have a statewide testing initiative, which is what I think we need, and maybe the Office of the Secretary can, you know, recommend that we put one in place as a part of our response to ending the epidemic in the state, right? But if we don't have a statewide testing initiative, which looks at groups like Ruston's or looks at groups like SOAR as our partners in being able to screen individuals. I mean, you know, we have food banks in this state. We have winter weatherization programs in this state where we're going to find some of the highest risk populations that we're talking about, both to be able to screen for HIV, viral hepatitis, but also to be able to get them linked to care and services that are also, I think, life-saving: food, water, you know, nutrition programs that are, I think, just are vital to their success. And so, you know, and I know, Harold, we had a bit of this conversation earlier, and I'm gonna come back to it because I just think it's critical that until West Virginia puts in place a screening program, we are going to keep coming back to this place, and that's not to say that it's not to say that I don't think the folks at the state are doing a job. I think they're doing a yeoman's job, but we've got these health departments that are county health departments with 3 and 5 people in them who are now doing kind of HIV work, substance use work, COVID work. I mean, our health departments, our health officers, and maybe I'm pleading a case to you now, Harold, but I think people think about health departments and they think about big city health departments. They don't think about the health officer having to leave the meeting for COVID to go to the meeting about whether or not cisterns are put in somebody's yard, right? Or that they're also responsible for the licenses for food handlers. I mean, these are not necessarily competing priorities, but for a lot of these local and county health departments, they are in fact competing priorities. How do you get the state to take this all on? You know, we've been trying to push the state to bring together an HIV group to start planning for ending the epidemic, to develop its community plan, along with the viral hepatitis plan, along with the governor's substance use disorder plan. There's only so many people so can we come together and work on those 3 things? Is that something that y'all could recommend?
Sure. So a couple of things. So I want to answer that question. I want to talk about HIV testing, because now under ACA, most insurance plans are covering HIV testing as a preventive service. So that also helps, so that we not only have sort of the federal funding, but we also have the Medicaid funding to support HIV testing in communities as well. So one thing that CDC and HRSA did several years ago was allow prevention planning bodies and the Graham White Part B care and treatment prevention bodies to merge and be one planning body that looked at the whole HIV care continuum. And the other thing that I have said is, to me, it doesn't make sense to come up with another EHG planning body. And you all know better than I do that in West Virginia, there's only so many people, you know, that you can pull together at these groups to be able to do this work. And given the fact that, you know, you've got your viral hepatitis folks, you've got your folks that are involved in substance use disorder, it makes sense to have one planning body that looks at the syndemic and sees where we can create these opportunities and partnerships. Because, and I would encourage on the federal level, we've encouraged the local government entity, the public health department, to do this. As we think about sort of a whole of society approach, you know, someone asked me a couple months ago about, you know, the role of public health in addressing sort of the social determinants of health. And did I expect that already strapped public health departments, like you just talked about, to do all of this? And I said, no, I don't. I said, but could they be the folks that bring other partners to the table to think about what's the role of employment in helping people maintain their health? What's the role of having housing or stable housing? And being able to have those conversations and think about how can our programs then work together? Because very often we're trying to stretch very limited resources in some instances to help the same communities that have these impacts. And so can public health do it all? No, but can public health be the doorway in which we bring and create some of these partners? I think so. And we could start that by merging some of these planning groups and looking at the syndemic impact of the infectious diseases, as well as who are the social and other clinical partners that we might need to have at the table as well.
Right. So Ruston, so how you say your other partner, your MAT partner, is the one that does the screening, right?
Yep, that's correct.
Right. So tell us what you do, because maybe.
Thank you. We've been working with community and youth for 40 years and trying to encourage the development of a healthy community. I mean, the truth is in West Virginia, people associate in small clusters all over the state, you know, but there aren't positive examples where those communities are getting stronger or the center of community life. We have we're trying to put a community prevention center approach, that it's a neighborhood center that's got some for young people, for old people, for better health. I mean, the truth is nobody invests in the place where people would go to live a more healthy life. It's like a community wellness place should exist. When I went to Iceland, that's what I saw, very different than what they have. And 20 years later, they have a healthy society that doesn't have substance abuse. But one thing they did was they invested in community solutions and neighborhood facilities and staffing. They trained professionals to work with community young people to delay the initiation of drug use. And that was their sole focus. And that's what I do. I'll be the last big push of our work will be every investment we can make in helping young people particularly have a quality life experience in their free time. And it moves the needle away from drug use and abuse and lifestyles that will cost our society billions of dollars if we don't stop it before it gets started.
And hey, Scott, so if people wanted to either get like a presentation from you, or actually more importantly, if they were looking for a grant or something out of Merck, because I think that's more of what, nothing personal, you do.
No, I got you, money.
You do a fine presentation, Scott, but really, where's the check at?
So and I'm going to answer that, Tony, but I did want to offer up too, because I just wanted to share this. I've been doing this like some of you guys, like 30 something years. And the strides that I've seen made in some of these places that are funding to do in the epidemic work. I mean, the great strides that have been made, really, I see have been tied to the degree that clinics, organizations that are doing testing, test their clients and then get them on treatment right away, either before they leave that day or shortly thereafter. So the fast start approach, and then following them to make sure that they're adherent, right? To make sure that the folks living with HIV suppress their viral load. And on the other side is to make sure that folks that are at a high risk are getting put on PrEP. And so that does bring up sort of the funding issue, but I will say this, that there really shouldn't be anybody in the state of West Virginia who tests positive that isn't able to access HIV treatment. That should never be a reason or a fear as to why testing isn't done, because there are programs available to ensure that everybody who has HIV gets on medication, gets on treatment, hands down, not even a discussion there. As far as PrEP, there are also programs to support individuals who need to be on PrEP. So I'll just say that about that. Now, as far as grants and stuff, so that is a piece that I do not handle at Merck. We have sort of a separate section of Merck where we have a firewall that I don't get involved in. But there is a site, since you've asked, Tony, msdgrants.com. That's a Merck site. And on there, organizations can go and request funding. And you don't have to wait for there's no RFA required. You just go on anytime you want and you put in for whatever it is that you want to do. Now, there are certain areas, and HIV is one of our areas that we do provide support in. So that's a good thing. And they need to be programs that focus on how we're going to support clients around advocacy and those kinds of things. So we're not going to fund a gala. That's not what the site is for. So I would urge people, if they're interested, to go on sooner rather than later, because there's a certain amount of money that's allotted every year. And this is about the time now to go and put their applications in. I mean, don't wait until October. Although there's no deadline, you can submit whenever, but when the funding is out, it's out. So you're at a good time now to do that if you're interested. So I hope that answers that question.
Yeah, it does. And maybe I think that someone was putting stuff in, Allison was putting something in the chat. It says, try this. West Virginia is a great place to start for small grants programs, for funding small grants or something like community gardens, hiking club, etc. We were talking about for community programs, right?
Right.
So yeah, Harold, I'm going to come right back to you. Brooke has had her hand up for a while, and I don't know how to use technology, so I didn't see it. So we're going to let her ask you the question, and then we're going to come to you. Go ahead, Brooke.
Hey, thanks. Brooke Parker. I'm a social worker with the Ryan White program in Charleston at CAMC, and I'm also an organizer with a grassroots harm reduction group here in Charleston as well, SOAR, West Virginia. And I don't have so much of a question, but we started an early intervention program at our ER here, the emergency department at CAMC General. And so we have an early intervention worker there with Ryan White program that's stationed. She's called every time that someone comes in with substance use disorder and seems to be a higher risk for HIV or any other co-infection. And she actually is able to test there on the spot with people and then have a confirmatory test if necessary. But it's been an immediate way to respond to concerns, and then because she's right there with them, she's able to link them to care immediately because they get a referral back to the Ryan White program Part C here. So that's been a really effective way, to link people with care and testing at the same time, because a lot of the people that are coming into the ER, like we were saying, they don't have a primary care provider. Most of them are unhoused, and most of them are in that IV drug user community. We've also been really encouraging our ED to screen for syphilis as well, because I know here, I don't know what it's like in the rest of the state, but I know talking to the infectious disease workers that we hang out with, the co-infection rate around here especially is like, it's getting to be out of control. And so many people are coming in untreated for HIV and syphilis at the same time. They're just so incredibly sick. So we've been really encouraging our ED to do that. And we've been working really hard to build out more of an outreach program with Ryan White so that we can go and do discrete on-demand testing when we've been working it out so that we can go to like the homeless encampments that are around Charleston, around Kanawha County, and working with our community partners to make sure that people that are living in a shelter, or like especially DV shelters, people that feel like they're higher risk, have access to testing, and it's not dependent on them walking into a clinic or a hospital and sorting through that whole process. It's just on demand, and it's immediate linkage and retention to care. So that's one way we've been working really hard to get testing and linkage to care out there. And then of course with our grassroots harm reduction program through SOAR, then we have Ryan White program comes out with us every time and offers testing. And I mean, every time we go out, they manage to, it seems like we're able to test probably 25% of the people that come out. So if we have, it's been a good way. We're learning a lot about meeting people where they're at instead of asking them to come to a clinic, come to a hospital, wait through the ER process. And we've been having really good success with that. So that's all I just wanted to say. I'm glad to be here.
Thanks, Brooke. Oh. And sorry about the article I read about not getting the money. Sorry. We'll
thanks.
We'll have to fight another day.
We're pretty tough. We'll get it.
Yeah. Right. And so Harold, I'm gonna bring it back to you.
I was going to say thank you, Brooke, for that, because that kind of innovation, the work that you're doing in the emergency rooms, are just the kind of programs that we're looking to scale up as part of the EHE work across the country. So it's great to hear that you're doing that in Charleston. And so now we need to think about how do we do this in other key parts of West Virginia as well. The other thing I wanted to share is that, Jared talked about Tennessee is working on an ending the syndemic plan. And as you think about sort of talking to Scott and Merck, or talking to other pharmaceutical companies, think about what would it be like if in West Virginia, given your current plate of service providers, if you were able to create sort of a no wrong door when it came to STIs, HIV, viral hepatitis, and substance use treatment. Even if I wasn't the provider that was providing all of those services in combination, I could link you to somebody who was. But when you walk into my door, so let's say, substance abuse treatment is my thing, that's my jam, I'm still gonna make sure you get access to an HIV, a viral hep, an STI test and screening. And then based on that and what your risk profile is, I'm gonna link you to prevention services, or I'm gonna link you to care and treatment. But you walk through the door here, I'm your dude, I'm gonna take care of you, but we're gonna make sure you get the whole comprehensive array. If you could pull a planning body together that could look at that, that would jumpstart you ahead of EHE, but also, I believe, cause you to really think about the funding that we currently have. How do we blend some of these funding streams have providers create new partnerships, work with our AETCs and CDC CBA providers to be able to help us reconfigure and reshape this. Then I think you could deal with those that might be lost, those not getting a diagnosis, and those who might need a more comprehensive package. Because what happens is individuals walk through the door of a service provider for the thing that is most critical. But I got all this other stuff going on in the background that is not dealt with. And so if you were able to think about how do we create those new partnerships? And if there is new funding in West Virginia, how are we going to use that to fill in these gaps and reconfigure?
Well, if I, we're at near the end of our time, and you've hit the nail on the head. And I don't know if we can, we have actually sent a letter to DHHR about exactly that, of suggesting that we put together a work group that is consistent across these various disease states, thinking that it would be more strategic long-term. And also people just don't have we just don't have the human capital to do it a different way. People that are invested, and let's let them all work. Let's let us all work together to get a comprehensive response and a comprehensive plan coordinated. And I've got two things that if I don't do, or three things actually, if I don't do, our team is going to kill me. One is that we are putting out a survey on capacity building needs and other needs of organizations in West Virginia, as well as other rural communities across the United States. I think that you'll probably get an email with this. We are giving away 3, 4, 5, 6 different gift cards for you. There's a provider version of the survey, and then there's an individual version of the survey. And you'll be getting that with a link to it with the meeting notes as we follow up with that. The other thing that I want to do before I jump is that somebody said that Fernando wants to share the West Virginia Hemophilia Foundation is looking at Orion White dental practices to replicate within our community. Also, we offer assistance for those with bleeding disorders within the HIV population. Harold said, ask the state to request TA from HRSA or CDC to integrate your planning process. Thank you very much. I will. So Harold, should I just do that, or should I call you to do that?
No, ask the state to do that. If they give you, so that they can contact their project officer and do it the right way. You can tell them that you talked to me and that the Office of the Assistant Secretary suggested that this would be a great way for West Virginia to go.
Right.
Marcus and Emma, I hope you're hearing that, and Amanda, so that draft letter for DHHR you'll be putting that together for us. And forgot to mention, Brooke said she forgot to mention, West Virginia Drug Intervention Institute is doing a survey. Ruston, I agree, bigger programs will be more effective, but sometimes you have to start small and start building. I agree with that too. Trina Scott is the HIV Community Liaison for Gilead Sciences. Her email is in the thread. The other thing that I have to do before I have to jump is to say thank you, Harold. And I really do appreciate it, Ruston, Scott. I do appreciate the time. I do know that we're in a crazy time in our country, but also in the survival of our communities. And I think that, Ruston talked about it. I believe in it. Community resiliency models are the only way that I see a way forward, is that we have to work together. Speaking of that, on the 19th, we normally only do one of these a month, but we will be doing a second one on the 19th with Dr. Deborah Burks of HHS also from Operation Warp Speed. We will also have Greg Millett, who will talk with us about the importance of communities of color and rural communities in vaccine preparedness and vaccine rollout in response to COVID. And we hopefully will get Dr. Clay Marsh from WVU. And last but not least, Dr. Lisa Fitzpatrick, who is also doing work with the Biden administration. So we will have the folks from the Trump administration, folks from the Biden administration, hopefully folks from the state as well. But we will be getting out. We can't put the flyer out till we have all the confirmations, but we hopefully will get that out within the next day or so. So again, thank you all very much. I hate to jump, but I have another call. But again, thank you, thank you, thank you. And let's keep doing it and keep making West Virginia a better place. Thank you.
Bye.